Thank Raju and Team Delhi for giving me the opportunity. So this is a mainly a fracture in adolescent patients. It's a rare kind of injury because I practice at a place. We have many boarding schools there, and these kids they play all kind of sports, right from basketball, footballs, and all that. So just a mention of this classification. These fractures have been classified as Ogden by Ogden. It is a simple 2 to 3 millimeter of avulsion, simple avulsion, then intra-articular extension. It's a type 3 kind of a Salter-Harris classification. The whole epiphysis is avulsed there, and a type 5 recently has been described in which there is an isolated patellar avulsion. And they have been further classified into displaced, non-displaced, comminuted, non-comminuted. So first case, do you find anything abnormal with this X-ray?
Since you are presenting, there has to be definite abnormality.
No, on AP, like we can't find anything. Like on lateral view, if you see, there is a little bit of like this kind of the proximal tibial epiphysis. It's actually lifted like that. So it's a type 1 Salter-Harris class injury. So what would you like to do? We'll do nothing. Yeah, so for this simple injury, we reduce it. Just a minute. Yeah, this is the C-arm images. We can see now just a traction injury. You should not actually lever them out because you can likelihood that you can injure the epiphysis. So this is nicely reduced, and a cast given like it's a bivalve cast. You should bivalve it. I will give the reason later on what can happen with these kind of injuries. Another case, it's an intra-articular extension while playing football, and usually they are picked on lateral view, not on the AP view. So would you like to, this is a next ARS question. Okay, just to mention here that why one should not do a percutaneous in these cases, because on the X-ray, the thing which is visible is only bone. So there is a lot of soft tissue components in these kind of fractures. So one should resort to an open reduction, not a percutaneous fixation. Just a minute. So ARS question 3, what kind of fixation you would like to do? So without a washer, yeah.
So Hemanshu, you have not included this in the choices, but can you imagine fixing them with suture anchors?
See, in 1 or 2 cases I tried with suture anchors, but sometimes like they are not adequate because there is a massive force which on the tibial tuberosity. So it is advisable in the literature also. They say if the kid is less than 11 years age, then you can use smooth K-wires. But the problem with the K-wires is that if you leave them percutaneously like out, so there are chances of infection. And it is better to use screws. And if the kid is more than 11 years age, then you should use screws, and preferably 4.5 mm screws. And once you have used a single screw and you have compressed the tibial tuberosity, then you can supplement it with fully threaded screws, not with the partially threaded screws, so that you don't compress it fully.
The solid screws, you mean? The fully threaded solid screws.
Yes, you can do that. So this was So fixation done. This is the most severe cases which I got. The whole of the proximal epiphysis you can see with the Thurston-Holland sign. Gentle close reduction in the emergency with the Kramer-Weiss splint. You can see they can reduce well. And these were MRIs which was brought because they are boarding school kids, so the money is not an issue. You can see the amount of soft tissue. You can see this whole thing from there to there. Even this, the edema is beyond the tibial tuberosity confines. So fixed with 4 screws. And would you like to use a tourniquet in these kind of injuries? Because in all our arthroscopic surgeries we use tourniquets. So, for 2 reasons, the tourniquet should not be used in these kind of cases. First of all, the tourniquet actually fixes your quadriceps here, and you have to reduce the extensor mechanism, so it will not get reduced fully. Second thing is the high incidence of vascular injuries in these kind of injuries. So you can actually aggravate the vascular injury by inflating the tourniquet. So reported incidence is less than 1% of all the epiphysis injuries. Usually adolescent males approaching the skeletal maturity have them. Well-developed quadricep musculature, injuries occur during the athletic activity, mostly jumping activities. A violent knee flexion against the tightly contracting quadriceps, as in landing from a jump. Violent quadriceps contraction against a fixed foot, as in jumping. So, along with these injuries, there may be rupture of patellar tendon, quad tendon, collaterals, and cruciate. And vascular compromise of the proximal tibial physeal fracture can be devastating. So this is just an algorithm we mentioned, but we have to be very pertinent our neurovascular examination in these cases. And to summarize, these injuries involving proximal physis is relatively uncommon, but can result deleterious consequences if poorly managed. Unrecognized compartment or a vascular involvement would be devastating for a young limb. So this is open for questions now.
I think for these injuries, we need to get a CT scan to understand the pattern of the intra-articular fracture. So to understand the trajectory of the screws. And the other thing is that we can put a scope inside to see whether the intra-articular reduction is proper or not.
CT in such a young child with such a heavy dose of radiation, do you really think it adds more value than what is given already by an X-ray?
Fracture as well to understand the trajectory of the screw. The same will stand here as well.
Himanshu, your comments?
See, CT and MRI both have been cited in literature that you can use to know the other injuries accompanying these kind of injuries. But like you can do it, there is no harm in doing that. Yeah.
I think more about how the fracture
But they are rare injuries. I have not seen in my almost so many years of practice. I don't know how many people how many of people you have seen tibial tuberosity avulsions isolated in adolescents?
Yeah, so it's a rare injury.
So it is less than 1% of all the epiphyseal injuries. Thank you.